I know you learned about urinalysis last semester, but we're going to just um, review it again. So a normal urinalysis has a pH of 4.5 to 8. If it's high, it could mean there's bacteria in the urine. You should not have bacteria in your urine. If you do, you probably have an infection. You should not have leukocyte esterase in your urine. Leukocyte esterase is secreted from white blood cells, and it lets us know that your patient does have a urinary tract infection if it is present. WBCs should be less than 5. Nitrates should be absent. Nitrates are secreted from E. coli, so that definitely means you probably have an infection, right? RBC should be less than 5 if if the urine is bloody or rusty or has more RBCs, the patient might have a problem with their glomerulus. Protein should be negative, ketones should be negative, and glucose should be negative. I talked about glucose spilling into the urine when it's over 220. Ketones would be positive if somebody was like breaking down fat in their body for nutrition. And then protein would be positive if there's something wrong with the kidney and it's letting protein leak through the urine. When you're getting a UA, it's best if you can do early morning if you can, but it really can be done anytime. And remember, it's a midstream, so they urinate a little bit, then they clean, then they go into the cup, okay? And it needs to be in the refrigerator if it's going to be, it can't be standing for longer than an hour. Okay, specific gravity it's a measure of the solutes in the urine. Okay, so if the specific gravity is towards the low end, it's more like water, and if it's towards the high end, it's got a lot of solutes in it. Okay, so the normal range is 1.005 to 1.030. Water is 1.000. So it measures the concentration of urine. That's what I talked about. And it will be high in situations where there's dehydration. And if there's glucose in the urine, it could be high. If somebody has SIADH, which is opposite of what you would think, right? Because they're not dehydrated. But this is the one instance that it would be high without dehydration, okay? If the specific gravity is low, it could be because your patient has DI and the urine looks just like water, okay? So the urinary output would be low. People on diuretics, if you have a high calcium, so hypercalcemia, it causes a nephrotoxic diabetes insipidus. That's why people with hypercalcemia have a large urinary output. Low potassium does the same thing. If the specific gravity doesn't change, and it's like 10-10, we call it, fixed, it means your patient has kidney disease. They can no longer concentrate the urine. So they have what's called a fixed specific gravity. All right, with the creatinine clearance, I had talked about this is what mirrors the glomerular filtration rate, okay? The normal is 70 to 120 milliliters per minute, which is very close to the GFR, right? The only way you can measure it accurately is to get a 24-hour urine. Remember that you have to go to the lab and get the big jug, put it in ice, put signs up in the room. The patient voids, you discard the first urine, and then you collect all the urine for the next 24 hours. And then you do the last urine at the end, okay? And remember, if you miss one urine, you have to start all over again, okay? And typically what happens is after you collect the urine, the serum creatinine is also drawn to compare. But yeah, just remember the nursing implications. Okay, the BUN is a value we do look at if somebody has renal failure. However, the creatinine is always going to be more accurate than the BUN if you get asked, because there is a lot of reasons a BUN could be high without renal problems. So the normal is 10 to 20. It increases with patients with renal problems, but also if there's non-renal, there are non-renal causes, like maybe you're on a ketone diet and you're eating a lot of protein. Okay, that can increase your BUN. If somebody has GI bleeding, that could increase the BUN because your body is going to digest blood in the GI tract as a protein. Dehydration causes a high BUN, and muscle breakdown also causes a high BUN. The creatinine is the most specific lab for renal function because it's released in your body at a constant rate. So, kidney disease is really the only reason somebody would have a bump in their creatinine. The normal is 0.6 to 1.2. And high creatinine, indicates kidney disease. All right, we're going to talk about some tests now. Now, kidney biopsy is the most definitive way to, figure out what's going on with the kidney, and it determines the cause of kidney disease. Like, say you had a patient that had an AKI or glomerulonephritis, and they don't know what's going on. They can do a kidney biopsy to determine what's going on with the kidney. Maybe they'll use contrast dye. I'm going to talk about contrast dye a little bit later, and you probably already know that that's damaging to the kidneys. Your patient needs to be NPO 4 to 6 hours before the procedure. You got to get the informed consent. You need to do the timeout, and make sure you do the pre-procedure checklist. Your patient is going to need coagulation studies because remember earlier I talked about how vascular the kidney is. So you can imagine if you put a huge needle in somebody's kidney, they could hemorrhage, okay? So you do the coagulation studies beforehand. And when I say coagulation studies, I mean the APTT, the PT, the INR, the platelets, okay? Because they're going to be at risk for bleeding. You position the patient prone. You can put like a pillow under their shoulders or their abdomen for comfort. When the provider is inserting the needle, you have the patient hold their breath. And this is to prevent a pneumothorax. Okay? You don't want the patient to breathe while the provider's piercing the kidney. Okay, post-kidney biopsy procedure, you want to prevent hemorrhage, okay? Remember, the kidney's highly vascular. So you're going to do your post-procedural vital signs because if the patient does start to hemorrhage, you're going to see tachycardia first, then tachypnea, then finally a low blood pressure happens a little bit later, okay? They're going to have a narrowed pulse pressure. You're going to hold pressure times 20 minutes. And don't forget what the frequency of the post-procedural vital signs are. Q4 times 15 minutes, Q2 times 30 minutes, and Q1 hour times 4, okay? You're going to put pressure on the puncture site for 20 minutes, and they'll put like a pressure dressing on it. I don't know if you've ever seen elastic type dressings that they put on for pressure dressings, but that's the kind they'll have on. Monitor for hematuria, monitor the dressing, make sure it's not getting saturated, monitor for pain. If your patient starts to complain, they're going to have pain. I mean, obviously, they put a needle in their back, right, in their flank. If they have radiation around to their back or their front, okay, or radiates anywhere, they may have a hemorrhage. So you're going to watch out for that. They're going to need to be on bed rest for up to 24 hours. So you want to keep them quiet. Now the kidney, fortunately, has a big capsule, a fibrous capsule that surrounds it with fat to protect it. So what you're trying to do is let that fibrous capsule tamponade the bleeding. So that's why you don't want your patient moving around and making a lot of gestures, okay? Coughing, sneezing, whatever. You want them quiet. Keep them quiet. Monitor for a UTI, which can happen about 72 hours later, and I think you know what the signs and symptoms of that are by now. Okay, a KUB is just a plain x-ray. It's a plain film. It stands for kidney, ureter, and bladder. And as you can see the kidneys in this picture, but they may do it like if somebody has like renal stones or maybe somebody has an intestinal obstruction, okay? Um, so maybe used to measure kidney size. Um, the nursing implications include no jewelry and no pregnancy, definitely, okay, before having a KUB. Okay, with a CAT scan, they can do this to determine kidney size, to assess the blood flow to the kidney. Typically, it's done with contrast media. So we have to talk about that because, the IV dye, it is toxic to the kidneys, all right? So you always, even if your patient doesn't have kidney damage, check the BUN and creatinine before somebody has a test with contrast dye. You hold metformin 24 hours before, 48 hours after a test with contrast dye because you're trying to prevent lactic acidosis and renal failure in your patient, okay? When the contrast is injected, you have to warn your patient that it's unbelievable. I just had a CAT scan. That's why I remember this. Um, the IV contrast makes you feel warm inside, but it goes in a sequence, like it starts in your throat and then travels down to your chest and all the way down your body to your pelvis. I mean, it's just crazy how it feels. You get this warm feeling. Um, Check their urine output. They need to be putting out urine if they have contrast dye. They're going to give them normal saline, which is good flushing fluid to flush out all the dye and make sure that their kidneys are being perfused. No jewelry, obviously, before a CAT scan. So the interventions are pretty telling. The other thing too is with a CAT scan contrast medium, it does contain iodine. So ask if they have an allergy to shellfish. They may want to give them some medication to prevent a reaction beforehand. A renal scan is another test that can determine renal perfusion and the glomerular filtration rate. It's a test that's done in nuclear medicine. The patient is injected with a radioactive isotope. They're not going to be radioactive after the procedure, so you don't need to worry about that. It's a good test for people that have renal insufficiency because you don't have to worry about contrast dye. Um, and they may get captopril, which you probably figured out is an ACE inhibitor during the test. So you would have to monitor for like orthostatic hypotension during and after the test and, tell them all the things like rise slowly, all those safety precautions you need to do for somebody that is on blood pressure medication. The voiding cystourethrogram. This will be done in patients when they suspect they have reflux of urine from the bladder into the ureters. So contrast dye is infused through an intermittent, like a straight catheter, and they fill up the bladder with contrast dye. Then they take the straight cath out, and while the patient is voiding, they take the x-rays to see if there's reflux. The trick question usually is about the contrast dye. In this case, you don't need to worry about the BUN and creatinine because the contrast never leaves the bladder. So it doesn't enter the bloodstream or reach the kidney. So you don't have to worry about lactic acidosis and kidney damage. So the IV pileogram is looking at the renal pelvis for structural disorders. And so some of the nursing interventions include NPO after midnight. They do have contrast medium, and it does go in the bloodstream, okay, with this. Laxatives. They got to clear out the bowel, and typically they get an enema before they have the test. And they do use IV contrast. So all those interventions we talked about earlier, like holding metformin, giving fluids, checking the BUN and creatinine, you would do that for somebody with a retrograde IV pileogram test.